Hello guys, hi everyone. So we will start with LIDS, lacrimal and sclera quiz discussion. All right. So henceforth we will have the discussion on the next day, 11 a.m. Okay. So the quiz will happen at 6 p.m. and 11 a.m. the next day we will have our quiz discussions. Yes, because very many of you who are not able to take the quiz also, you can take the quiz through the night where I give you the link on the EyeMentor app. So you can go to the free test sections under the EyeMentor Dr.Rajarathna app and take the test. And morning 11, we can discuss the questions. All right. So let's start with the first question. All of the following are seen in blepharophimosis syndrome except. Okay. So this is something to do with ptosis. So blepharophimosis syndrome. So the full form is BPES, that is blepharophimosis epicanthus inversus syndrome. Okay, BP, blepharophimosis, E, epicanthus inversus syndrome, BPES. So all of the following are seen except, so we need to find out the finding which is not seen in BPES. Option A, telecanthus. Is telecanthus seen in blepharophimosis syndrome? Yes, very much seen. And what is telecanthus? Telecanthus is increased distance between the medial canthi. You know which is the medial canthus, no? This is the medial canthus. So increased distance between the medial canthus, that is telecanthus. Okay, increased medial canthal distance. So that is present. Option B, hypertelorism. See, hypertelorism is widely spaced orbits. The bone itself is, the bony skull itself is a little abnormal. So you have widely spaced orbits, that is hypertelorism. So hypertelorism is not present in BPES, only you have telecanthus. So what is the difference between telecanthus and hypertelorism? See, telecanthus, the bony orbits are normal, only the distance between the medial canthi is increased. Okay, so there is an increased medial canthal distance, but if you check the interpupillary distance, that will be normal, a normal IPD. Yeah, but if you look at hypertelorism, the medial canthal distance is also increased and the interpupillary distance is also increased. Okay, so hypertelorism is not present in BPES, but anyway, now we already got the answer. Let's look at option C and D. Option C, blepharotosis. Ptosis, no, that only is blepharotosis. Blepharo means lid. So blepharotosis is a full word. Okay, so that is present. And epicanthus inversus, yes, of course it is present. That is the name of the syndrome, blepharophimosis epicanthus inversus syndrome. Yes, so epicanthus inversus is present. Okay, so let's move to the second question. A 40-year-old woman presents with redness of the right eye with mild to moderate pain which is increasing intensity over the past 1 month. There is no discharge nor visual complaint. What is the most common cause of her eye condition? So what is this eye condition that we are talking about? See, there is no discharge, so it is not conjunctivitis. There is no visual complaint. There is redness and there is a little bit of pain. See, I have already given you the diagnosis for acute red eye. Yes, so acute red eye, it can be episcleritis, it can be scleritis, it can be keratitis, anterior uveitis, it can be an acute angle closure attack, can be orbital cellulitis where there is a little bit of redness, or endophthalmitis. There are so many causes. Yes, now there is no visual complaints, so that rules out your keratitis, most of your keratitis. Okay, because if it is peripheral keratitis, then it's different. But your central corneal ulcer and keratitis, that is ruled out. Then number 2, anterior uveitis is ruled out because there is definitely some kind of vision disturbance there, vision is decreased. Then endophthalmitis is ruled out because vision would be decreased. Orbital cellulitis is ruled out because vision would be decreased. Here vision is normal. Okay, and there is a little bit of pain. Episcleritis, there is no pain. Anterior scleritis, there is pain. Posterior scleritis, there is pain, but vision is decreased. Anterior scleritis and episcleritis, the vision is normal, like in our patient. Okay, so most likely this is going to be anterior scleritis or episcleritis. Okay, and the pain is moderate pain, mild to moderate pain. So the diagnosis is more in favor of anterior scleritis. Okay, now what is the most common cause of our eye condition. Okay. Now, even otherwise, if we didn't even arrive at the diagnosis, can we look at the options and still arrive at the answer? So, let's say I've kept, based on my redness, I've kept conjunctivitis in my differential, then I've kept episcleritis, anterior scleritis, then uveitis, conjunctivitis. Now, let's see the options that they've given. Osteogenesis imperfecta. See, osteogenesis imperfecta is typically characterized by blue sclera, nothing else. So, blue sclera is a painless condition. Here they've said red eye. So, osteogenesis imperfecta is ruled out. Tuberculosis, there's nothing suggestive of tuberculosis here. See, episcleritis can happen in tuberculosis, anterior uveitis can happen in tuberculosis. But here they've told us, except for the pain and redness, nothing else, no other symptom. The vision, they particularly said, vision is normal. So, tuberculosis is ruled out. Sarcoidosis can cause anterior segment involvement, like anterior uveitis, it can cause episcleritis, scleritis. But again, no anterior uveitis now. But is sarcoidosis or tuberculosis the most common cause of episcleritis or scleritis? No. Rheumatoid arthritis, option D. Yes, because our diagnosis of this eye condition is anterior scleritis. Yes, mild to moderate pain, there is redness, vision is normal, no discharge, nothing else. And that age group, look at that age group, she is a 40-year-old woman. So, very characteristically rheumatoid arthritis setting in at that age group. And what is the most common cause of anterior scleritis? Rheumatoid arthritis. See, that is the only difference. See, earlier days we used to ask a simple one-liner which used to be most common cause of anterior scleritis. And you know the answer is rheumatoid arthritis. But now I'm giving you the presentation of an anterior scleritis, clinical presentation, and asking you for the diagnosis. Is that clear? So, here and asking you for the diagnosis and the most common cause of that diagnosis. So, it is anterior sclerosis. So, the most common cause of anterior scleritis is rheumatoid arthritis. Okay, question number 3 is a one-liner. Type of collagen present in sclera. What is the type of collagen present in sclera? It is type 1. See, both cornea and sclera type 1. Main collagen in cornea is also type 1. Sclera only type 1. The only difference is the irregular arrangement of the collagen in sclera makes it white and opaque, whereas in your cornea it's very regularly arranged, the main type 1 collagen, that is why it is transparent. Good morning BU, good morning, nice to see you. Okay, so hereafter we'll have it at 11 a.m. Okay. So 6 p.m. we'll have the quiz and 11 a.m. we'll have the discussion the next day. So that through the night you all can take the quiz on the EyeMentor app, even if you've missed the quiz on Telegram. And yeah. So type 1 collagen in both sclera and cornea. Although in cornea you also have the other collagens, type 1, type 3, type 5, type 6. Sclera type 1 only. Okay. Now the next is an image based question. So the image shows, okay, so what is the image? So look at this image and this image. Okay, so here, okay, look at this image, the mouth is closed, you can see the ptosis in this eye. Yes, can you see the ptosis? Now the mouth is moved, so there is a lateral movement of the jaw, and look at this eyelid, it is elevated. So what is this phenomenon? This is Marcus Gunn jaw winking phenomenon. So whenever there is a jaw movement, because the external or your lateral pterygoid is moved, what is the nerve innervating this? The trigeminal, the mandibular division of trigeminal nerve. It will also innervate your LPS. See, normally LPS is innervated by your third nerve, oculomotor nerve. But in this Marcus Gunn jaw winking phenomenon, there is a miswiring where your V3, mandibular division of trigeminal nerve, anomalously goes and innervates your LPS. So every time there is a firing to the lateral or external pterygoid, which the V3 normally innervates, the innervation also goes to the LPS. So the extra innervation makes the LPS lift the lid. See, there is a ptotic eyelid here, and now it's going up. And when the jaw comes back to the normal position, the lid will fall down. So it goes up and down, up and down, up and down, as if you're winking or the child is winking. So that is Marcus Gunn jaw winking phenomenon. Okay, it's also called as trigeminal ocular synkinesis. Okay, so it goes to the LPS, no, the trigeminal nerve. So this is called a complicated ptosis or a complex ptosis, because there is a congenital ptosis along with other findings. Okay, so this is Marcus Gunn jaw winking phenomenon. Next question, adhesion of the eyelid margins. If the eyelid margins are fused together, broad based fuse, or if there are small skin tags between the two lid margins, what is it called? Option A, ankyloblephron. Option B, blepharophimosis. Option C, symblephron. Option D, lag of thalamus. What is it? What is the answer? Ankyloblephron. So when you have those skin tags, adhesion between the lid margins, and it is usually congenital, and it can be seen in syndromes. It can be an isolated anomaly, or it can be part of syndromes like Hay-Wells syndrome or AER syndrome, that is ankyloblephron ectodermal dysplasias. Okay, AED syndrome, and in those there can be cleft lip, cleft palate, so you have to examine the baby completely, and also there can be cardiac defects, there can be cranial anomalies, so you have to do some imaging and get a cardio opinion, a pediatric cardiologist for these small neonates. Okay, so that is important. What is blepharophimosis? Blepharophimosis is there is ptosis, and also it is narrowed horizontally. Okay, so the palpebral fissure height is also narrowed, the width is also narrowed. It's like a constricted eyeball, a small eye that you can see. So that is blepharophimosis. Lag of thalamus. What is lag of thalamus? Lag of thalamus is inadequate closure of the lid margin. Okay, incomplete or inadequate closure of the lids, which occurs in Bell's palsy or extreme proptosis, when the eyeball is protruding out. So that is your lag of thalamus. What is symblephron? Symblephron is your conjunctiva, your palpebral conjunctiva and your bulbar conjunctiva adhesions sticking together. Yes, or we can say the eyelid and the eyeball are adhered. That is symblephron. Okay. Now the next question, again a very very important question, often asked question. Most common lacrimal gland tumor. Option A, lymphoma. Option B, pleomorphic adenoma. Option C, adenocystic carcinoma. Option D, mucoepidermoid carcinoma. Very very simple answer, pleomorphic adenoma. Okay, pleomorphic adenoma. I'll answer your question BU just a minute. Okay. The nasolacrimal duct, the NLD, opens into. Where is the NLD? NLD starts from the lacrimal sac and opens into the nose. Now, where in the nose? So, inferior meatus, lacrimal punctum, middle meatus, superior meatus. It opens into the inferior meatus. Okay. So, it rounds downwards, backwards, and laterally, and it opens in the inferior meatus. Okay. The NLD, nasolacrimal duct, and at the inferior meatus is where the valve of Hasner is present. Alright. Okay. Question number 8. Which of the following conditions is characterized by pain and visual impairment? Okay. So, characterized by pain and visual impairment, scleromalacia perforans. I told you scleromalacia perforans is painless. Okay. It is painless because it is the definition is it is a necrotizing anterior scleritis with no inflammation. Underline that, no inflammation, so no pain. Our question asked which of the following conditions is characterized by pain and visual impairment. So definitely not scleromalacia perforans. Posterior scleritis, yes, we do have pain and visual impairment, yes, but let's also see if there's a better answer. Anterior scleritis, there will be pain but no vision impairment, no. So that is not the answer. Episcleritis, there will be redness, maybe a little bit of pain, but again no visual impairment. So what is our answer here? Posterior scleritis. Yes. So posterior scleritis, you will have pain, eye pain and visual impairment. And if you do the imaging, probably we will see the T sign, the horizontal T because of the subtenon's fluid. Yes. Alright. Next question, normal tear breakup time, T-but. The normal tear breakup time is less than 10 seconds, more than 40 seconds, more than 10 seconds, less than 30 seconds. So it should be 10 seconds or more. Okay, so more than 10 seconds is your normal T-butt. Your tear breaks up into multiple islands. So what is the normal? Normal should be at least 10 seconds. So more than 10 seconds is our answer here. Now the next one is an image. So the image shows, so there's something to do with the eyelashes. What can you see? What is the finding that you can see? And you tell me what is the answer. Let me read out the options. You type the answer for me. Distichiasis, trichiasis, poliosis, squamous blepharitis. Let me read it out for you again. The image, so those of you who joined late, so this is the image, okay. It shows distichiasis, trichiasis, squamous blepharitis, poliosis. So what can you see and what is the terminology? Yes, guys? Very good, poliosis, very good, because you can see the graying or whitening of the eyelashes. Yes, typically it is premature. Yes, so that is poliosis. Very good. All right. See, symblephron is adhesion, as I told you, adhesion of the palpebral and the bulbar conjunctiva. So whenever you have raw conjunctiva, raw conjunctival surface, yeah, it can stick to each other. When will you have a raw conjunctival surface? Typically after a thermal injury, heat injury, some steam fell on the eyes, or radiation injury, or chemical injuries, or Steven-Johnson syndrome, where there is the mucosa affected and you have raw mucosa, because conjunctiva is nothing but mucosa. And we have an ocular autoimmune disease called ocular cicatricial pemphigoid, OCP, ocular cicatricial pemphigoid. So it can happen even in OCP. Okay, so those are the, yes, very good, correct. So those are the causes of symblephron. And coming to poliosis, yes, poliosis is typically seen in VKH syndrome, Vogt-Koyanagi-Harada syndrome. All right. Okay. Any other questions? All right. So today's 6 p.m. quiz on Telegram would be on opthal investigations and instruments, 6 p.m. And those of you, if at all you missed the 6 p.m. quiz, the quiz will be available for 24 hours on the EyeMentor Dr.Rajarathna app. I've given on the video description how to download the app. So once you download the app, it is on the free test. Okay, on the left side there's a menu, and there it will be free test. On the free test menu, you will have the quiz available there. All right, and so today 6 p.m. we'll have the quiz of opthal investigations and instruments, and tomorrow 11 a.m. I will see you here with the discussion. All right, you're most welcome. All right, see you guys. Bye. Good day, all of you.